Hi, I'm Dr. Stephen Pipe. I'm a professor of pediatrics and pathology at the University of Michigan. I'm actually a pediatric hematologist. I've specialized in hemophilia care for about over 30 years, and in recent years, I've been quite involved in clinical trials for novel therapeutics for hemophilia, and including gene therapy. And I've had the pleasure of being an investigator on the Hope B trial, which is the phase 3 study for Etranacogene dezaparvovec for Hemophilia B. So the Hope B trial now has 4 years of follow-up. And for AAV-mediated liver-directed gene therapy, which is the current era of gene therapy for hemophilia, long-term follow-up on both safety and efficacy is still of utmost importance for this community. We have a plethora of available therapeutic interventions for hemophilia, including for hemophilia B. But patients with these choices, they want to know if they're going to select a therapy that is potentially a curative over the long term. What does it actually deliver for long-term efficacy? What does it really mean for their lives? And what are some reassurances about the safety if they choose this therapy? So now that we've had 4 years of follow-up for the 54 individuals who've participated in this study, I think this is a really important data. Just to orient the audience here, Etranacogene dezaparvovec is an AAV5 vector. It's packages a transgene that includes the highly active factor IX Padua variant of factor IX that's under direction of a liver-specific promoter. And this was delivered to adult males with severe or moderately severe hemophilia B up to a factor IX activity of just under 2%. And now that this cohort has had 4 years of follow-up, the things that we really wanted to look at is what's the durability of the factor IX expression after receiving this treatment? What does the hemostatic, essentially the bleed control look like? What's the implications for factor IX consumption? The standard of care for factor IX deficiency, hemophilia B, is regular IV infusions of factor IX. So after you go through this gene therapy treatment, what kind of residual need for factor IX do you need? And then also importantly is what does the safety data look like over 4 years post-treatment? The nice thing about this study is after the patients were screened into the trial, they were all followed with a standard of care continuous factor IX prophylaxis, and this established the baseline data for us. And then after we had that 6 months of data, every patient got a one-time single infusion of Etranacogene dezaparvovec. This is at a dose of 2 times 10 to the 13th genome copies per kilogram. And then they were followed weekly for 3 months, then monthly for the rest of the first year. And then in recent years, from the end of year 1 till now the end of year 4, we've been seeing these individuals twice yearly. Now, there's something really unique to this clinical trial program, and that is, the exclusion criteria. So common to all AAV-mediated liver-directed gene therapy is the patients coming into this are adults who are either severe or moderate severe. They couldn't have had a history of factor IX inhibitors. They couldn't have any active hepatitis, although they could have a history of treated hepatitis. In this trial, they could have had a history of HIV infection, but it had to be well controlled. And because we're targeting the liver, we had to demonstrate that they had no advanced liver fibrosis. But uniquely, we evaluated pre-existing neutralizing antibodies that are directed against this specific AAV capsid, the AAV5 capsid. This was assessed in all the individuals, but it was not used as an exclusion criterion. And you may know from the pivotal data that was reported that led to approval for this program is that AAV antibodies are not an exclusion for being able to receive this. And this is unique compared to other AAV therapies. We now have the opportunity at this presentation at EHAD 2025 to let people see similarities and or differences between the cohort of patients who were neutralizing antibody positive versus those who were neutralizing antibody negative. It was about just under 40% of the patients who actually had neutralizing antibodies. Now, what we knew from several years ago, there was one individual who had a very high titer against the AAV capsid. His titer was over 3,200, and he was not a responder. All of the other 21, all of the other of the 21 individuals who were positive for AAV5 neutralizing antibodies had titers that were 678 or below. And for the most part, they have all been responders in this trial. There was one individual, and this was reported previously, who had an infusion reaction early on when getting Etranacogene dezaparvovec, and the study team decided, based on some other comorbidities in the patient, that they would not continue the infusion. So that individual only got 10% of a dose, and he was also a non-responder. So what we then have is 52 of the 54 patients who we consider the initial responders. And when we look at the differences between the baseline characteristics of the neutralizing antibody positive versus neutralizing antibody negative group, they really are quite similar. And importantly for this cohort of patients, the participants on their standard of care factor IX prophylaxis, it was really a minority who experienced 0 bleeds during that 6-month lead-in period. It was only about a quarter of the patients who had no reported bleeds. So this is what we're now looking for post-treatment, is how much better did they do after receiving Etranacogene dezaparvovec. Now, for the analysis set that we had to present at EHAD, there were a few patients who have been lost to follow-up, and this is important for everyone to hear as well. So we had one individual who passed away early on in this trial. It was unfortunate. It was a urosepsis in an older patient, and he succumbed to the infection. It was unrelated to receiving this treatment. There was another individual who's also reported previously who developed hepatocellular carcinoma. This was deemed to be related to his pre-existing hepatitis as well as some other risk factors, and he went on to have a liver transplant. So now that he has a brand new liver, his efficacy data really is now excluded from this safety follow-up data. And then the one individual who was a non-responder because of the high titer, he actually withdrew his efficacy consent after being followed for a couple of years, so we don't have his additional data. So this 4-year data cut still is substantially populated by 51 subjects for the efficacy endpoints and 53 subjects who have the safety endpoints. And the most critical thing is, after receiving Etranacogene dezaparvovec, what kind of bleed control did they experience? Because they all stopped their standard of care factor IX prophylaxis. And what we see is that as compared to their annualized bleed rate during the lead-in, which overall was about an ABR of 4 for all bleeds, and it was 1.5 for spontaneous bleeds and 2.3 for joint bleeds. What we see is that the annualized bleed rates across each of the years has been close to 0. And if we look at the year 4 data particularly, it's been very low. So patients are having durable control of all bleeds, spontaneous bleeds, and joint bleeds. And notably, 60% of the participants have experienced no joint bleeds over 4 years of follow-up after receiving this therapy, which I think is really quite remarkable. And if we look at was there any difference between the NAb positive group and the neutralizing antibody negative group? Well, what we see is very similar reductions in their ABR, with an 85% and 75% reduction for NAb negative versus NAb positive. So it didn't seem to matter what your neutralizing antibody status was within that range that I gave you. You still had a good efficacy from this treatment. Now, there's one patient, this has been reported at previous meetings, there's one patient who returned to continuous factor IX prophylaxis at month 30. This was a patient who had a fairly modest response to the gene therapy, and then by month 30, his bleeding phenotype was starting to return, and his factor IX was less than 5% level, and so the study team decided to resume prophylaxis with that patient. That's the only patient who, after being an initial responder, has returned to prophylaxis to date. And there have been no further individuals who've resumed prophylaxis as we move from year 3 to year 4. Critical thing with response to this treatment is, what are the endogenous factor IX activity levels over time? And what we're seeing is at year 4 post-treatment, 98% of the evaluable participants had factor IX levels that were in the mild range or higher, so above 5% at least. And then a third of the evaluable participants actually have factor IX activity levels that are in the non-hemophilia range. So essentially, they have achieved stable and persistent levels that are in a range that is similar to individuals who do not have hemophilia. And accordingly, then, you can imagine that the need for factor IX use has almost completely evaporated during that time. And so since 60% of the individuals have had no bleeds over that time frame, they really have had no particular need for factor IX over the course of 4 years. And so what we're still seeing over 4 years of treatment is about a 95% plus reduction in factor IX consumption. And this is important for the community here, because this is the key cost effectiveness impact of gene therapy. You go from therapy where in the lead-in phase, the number of IUs per year per participant was over 250,000 based on their lead-in data that was collected, and those numbers have now dropped to less than 10,000 IUs per year per patient, and that includes the individuals who had to resume their factor IX prophylaxis. So if we look overall, there is 25 of the 54 participants who've never received any factor IX infusion over a 4-year period post-treatment. And then really the final thing to sort of wrap up this 4-year data cut is the important safety outcomes. So importantly, no factor IX inhibitors. We've had no thrombotic events. I mentioned the one individual who passed away with the urosepsis had been reported previously. There have been no long-lasting or late AAV-related toxicities. And one of the things that the community continues to look for accumulating data is, does AAV treatment in any way increase your risk for malignancies? This has not been observed in any of the long-term studies previously. It's not been observed from the best preclinical models we have in other animals. But in this clinical trial, we've had 3 malignancies reported. They've all been undergone molecular analysis, and all 3 of them have been deemed to be unrelated to the AAV treatment. So that, again, remains encouraging. So these are just malignancies that occur sporadically in the population that we see when you follow this age of individuals over a very long period of time. One thing that I found really reassuring from the trial for this data cut are the treatment-related adverse events over 4 years. So the most common treatment-related adverse event was an evidence of liver toxicity, which is manifest by an increase of a liver enzyme called ALT. It's a type of transaminase. This only occurred in 10 individuals over 4 years of treatment, and in 9 of them it triggered a course of immunosuppression. But all of these happen within the first 6 months of treatment. And actually, if we look at when they started, they were actually very early, within essentially the first 3 months of treatment. All of the transaminase elevations had resolved through 6 months of follow-up after treatment. All the patients who started on immunosuppression were finished by the 6-month point. And then subsequent to that, there have been no ongoing issues with any evidence of liver toxicity related to this treatment. And so I think that's really encouraging for people to hear, that there doesn't appear to be any ongoing adverse impact of this treatment at the level of the liver. We did see some infusion reactions. I mentioned the one individual. Overall, there was 7 of the participants who had infusion-related reactions. These are usually quite manageable. They're self-limited over a day or two. Usually they're interventions that most centers that manage hematology patients are quite familiar with managing, and can be treated on site without too much difficulty, and all those other individuals, it resolved without any consequence. I think this is really encouraging data. It's important data, and it adds to our overall insights on the long-term safety and efficacy of AAV-mediated liver-directed gene therapy for hemophilia B, and specifically for Etranacogene dezaparvovec. Yeah, so at our center, we've had several patients in this clinical trial program, so they've all rolled over to what we call our long-term study. So this is going to continue to follow these patients who've been now 5 years post-treatment, now for the next 10 years. So this is going to give us a very long-term outcome data over this next decade. And I think, again, informing on both the durability of the efficacy as well as the ongoing long-term safety. So that's what we're going to continue. As well, patients are now getting this commercially. You know, this treatment was approved a couple of years ago, and we've been starting to see patients receiving this in the commercial setting. Their data now is also being collected globally. There are national studies. We have a national data collection system in the U.S. called ATHEN, American Thrombosis and Hemostasis Network, and then we also have the World Federation of Hemophilia Gene Therapy Registry, and they're collecting data from commercial patients who received this therapy, and that data all is going to be pooled together, including from other countries, and that will allow, again, another data set for reporting out the safety and efficacy. The other thing that's happening is these are such encouraging results, and I mentioned at the beginning that I'm a pediatric treater. I have a number of adolescents who I think this could be life transformative for them to be able to undergo this treatment while they're still adolescent age group. We believe biologically that the liver is mature enough to receive this therapy probably at about age 12 or so. So what I believe you're going to see happening, there is a study protocol that's coming from the study team here for Etranacogene dezaparvovec that's going to look to deliver this therapy to adolescent patients. And we'll probably start with the upper bounds, the 16 and 17-year-olds, but then as we get some efficacy, we'll be able to move down to the younger patients. And when you think about, what a teenager's going through and some of their life ambitions, etc., to have a therapy that can deliver this kind of safety and efficacy that we reported at EHAD, I think this becomes a great option to be able to talk to families about.